you came out with a controversial article nung April 1. I'd like to ask you to explain what you mean. Kasi you talked about you talked about terrible choices that have to be made, including choices about resources and allocating resources. You talked about it not being right to continue offering advanced care for all, and the need to choose to limit invasive care in favor of comfort care and palliative care. In layman's terms po, what exactly did you want to say?
I wanted to make sure that our people actually started talking about what it meant to them, because they didn't know what someone goes through when they come into ICU. I wrote that article kasi so we're 1 year into the pandemic, and I was thinking to myself, normally I'm very, very proud of the medical city's intensive care unit. We're one of the most advanced in the country. We have been beating the odds when it comes to patients surviving their critical illness, except when it came to COVID-19. So I was always wondering what was different. COVID-19 is a novel disease. The world was learning how to treat it. There were resource problems already, even in the beginning. But besides that, we weren't performing very well. And when I spoke to some of my colleagues in other ICUs, and they had the same problems. And in March, the Society of Critical Care Medicine came out with this article from 16 countries, and they had 20,000 patients. They looked up the outcomes, and they were all very bad. So I mentioned that a little bit in the article, and it made me think, if the outcomes of these patients are all very bad, it is probably not right that we keep on pushing intensive care the way that we understand it, which is basically invasive care, being away from their families. And in that situation, especially when there are resource limitations, isn't it more humane also to start talking about alleviating distress, alleviating the symptoms, rather than seeking for cure? It might mean dying, but it might be actually dying without suffering. And therefore, we started talking more about the importance of palliative care, which really is a discipline that talks about alleviation of symptoms, and not just the distress of the patient, but also the distress of the family.
Of the family.
Yeah. So it's kind of weird kasi I'm an intensive care doctor. My whole training is about invasive care. And my advocacy now appears to be the complete opposite, which is staying away from intensive care and choosing comfort.
Well, you did say that this was going to be a difficult conversation. And yeah, I can't even begin to imagine how difficult it will be for doctors. Just the other night, we asked about your article to Dr. Limpino. And I remember that her immediate reply was, "We're doctors and we're not to play gods." Just off the cuff, what is your reaction to a reaction like that? That you are not to play gods, that for as long as somebody is still living, that there's hope, and you may not decide on behalf of that dying person.
I agree,
Yeah, your
Dr.
thoughts?
Limpin. We are not gods, but we need instruments and we need equipment to save lives. So I consider myself a pretty experienced intensive care doctor, but I'm completely useless if I don't have the equipment that I will need to save someone's life. Now the conversation is difficult, and you did say that it will be very difficult for doctors to have that conversation. But I was not even just talking about that. I was talking about the conversations that we needed to have in families. Long ago, I actually talked to my parents about this because they're getting elderly too. They're getting older, and so they're actually the ones that are at risk for this kind of worsening and intensive care. And we needed to make sure that we were following their wishes, and we needed to know how far they wanted to go. So I'm kind of clear about their wish is not to undergo intensive care. The question is now, did a lot of families talk about it?
Mm.
So that is actually the thing that is more important. The conversations need to start at home. The conversation with the doctor should come later after you have clarified your wishes with your loved ones and with yourself.
I hear what you're saying. At the same time, I think there's a level of me that I don't want to hear what you're saying.
Right.
So maybe just to clarify it, let's role play a little bit. Let's say I come to the hospital. I bring, let's say, a relative of mine, elderly, let's say mid-80s, mahirap na. On top of that, marami na talaga siyang sakit. Severe ang kanyang condition, nahihirapan na siyang huminga, and so on. And I come to you and I say, Doc, ano bang gagawin namin? Pwede bang idiretso yan sa ICU? What do you tell me?
Yeah. So if the patient, I'm assuming already, is going to be heading towards mechanical ventilation, I would be saying that ito po yung i-expect natin. If they go po to the ICU and requires mechanical ventilation, the chances are really that they will not make it out. And I will lay it flat like that. And it's not the same technique that are used by many people. But I think people are sophisticated and mature enough to actually hear the truth, and not be, we don't sweeten it, we don't candy coat it, because it is a disservice, actually, I think, if we don't tell them the flat truth, especially early. So I'll be
But
telling them, that, actually, because they need to know what the chances are of coming out of the hospital once they have come in. And then I'm going to say that there is actually an option of not going to the ICU. And if you choose not to go to the ICU, not to undergo the invasive ventilation, not to undergo the invasive lines, the dialysis, all that, we can keep your loved one as comfortable as possible by using special medicines, making sure that they're as comfortable as possible, understanding that they may actually die from this disease during the course.
Now, to be clear, kung si Bok ang dumating at may kasama siyang isa pa ring matanda at yung mas bata ng konti yung pasyente niya, mas malaki yung chance, pero ako pinanindigan ko na hindi, I want my elderly to have as much care as possible, including all the facilities na nauna ako and so on. At what point does the things get out of my control or out of Bok's control and completely in your control?
If we're talking about the last bed in the ICU or the last ventilator in the ICU, then yes, these triage decisions will be necessary now.
I suppose you have talked to a lot of your colleagues about this. This is a conversation that you have begun. I mean, I know it is really part of triage. From the very start, it was part of triage, but it's a part of triage that nobody really wants to talk about it. How is the conversation going on in the medical community? I know you said it. We have to talk about it among family, but from your end, from your sector, how is it going?
It's very uncomfortable, actually. To tell you the truth, everybody is uncomfortable with it. I myself am uncomfortable talking about this. No one wants to address it, but it's necessary now. So we have to basically work through this pain and basically try to do the best for our patients, the best for our society, without feeling so crazily bad about ourselves at the end of the day.